And there was, excuse me, there were no prior symptoms. There were no prior signs that something was brewing, other than him being a smart kid. So he was very popular around town. He was athletic. So it really took us by surprise. It was a very challenging time in the lives of my family and my own life. Obviously, my family kind of coming to grief with that was a very difficult thing. So I think that put me probably on my path, right? So I struggled a bit through high school because I didn't know kind of what was going on. I spent a lot of time in the counselor's office trying to figure myself out, and eventually got into college, not knowing what I wanted to do. And I naturally fell backwards into psychology. It just seemed to fit. Next thing I know, I've got a master's degree in mental health counseling, and I'm a licensed therapist. So I got into the field initially just working in the community. I worked in various school systems as a therapist to kids in inner city schools. I did a program of assertive community treatment, which is out in the community and outreach to people that are homeless or otherwise living in impoverished areas. Eventually found myself back where I did my internship on an inpatient psychiatric unit. I absolutely loved this job. I spent 10 years on an inpatient psychiatric unit as a therapist. We called ourselves treatment coordinators because we were technically not social workers. I was a licensed mental health counselor, which here is the same as an LPC. So I spent 10 years doing that job. And during that time, I had a lot of angst about why we did things the way we did things, and we could do it better and more efficiently. And eventually my boss looked at me and said, I'm tired of you criticizing us. Why don't you try? And so he gave me an opportunity to become a leader of that department. It was a great learning experience for me, opened my eyes to just how challenging it is to actually be a leader. And that led me to some great experiences. I learned a lot about healthcare in general, hospital operations. I got to go to some of the bigger meetings. Well, eventually, my wife and I were having kids, and the question was, my family actually retired. They're restaurant owners. They moved back to Greece. Her family all moved to the Virginia area, and we said, okay, so if we want to be near family, we need to decide if we're going to move to Greece or we're going to go to Virginia. So we moved to Virginia to be near her family, and I took my first job as a director of geriatric hospital. We had a geriatric 15-bed program at Lewis Gale Allegheny in Virginia. First opportunity as a director, awesome program. Got to work with geriatric patients and really learn a lot about nursing homes and kind of the Virginia process for mental health. They have a whole different system there based on a tragedy that happened some years back. At any rate, in living near her family, we're about 2 hours away. I always say it's close enough that we can visit on weekends, but not so close they can just pop in for dinner. I thought it was a great arrangement. At any rate, in those 2 years, we spent a lot of time visiting them, but they didn't spend a lot of time visiting us. So my wife and I kind of looked at each other and said, hey, if they're not really going to come see us very often, why don't we move somewhere we want to be? And Florida was always a destination for us. So we moved to Florida, the Panhandle. I took a job in the Panhandle of Florida and did about 4 years there of kind of building up that program. I got very involved with the community and even with the state level. Some of the logistics about how mental health is administered. The Baker Act in Florida has some challenges to it. So I also want to mention I became the president of the NAMI affiliate of Okaloosa Walton while I was there. So I have some experience working with NAMI and some of the challenges and services that they provide. Really fell in love with that. Eventually, I was offered a second facility because things were going well. I had 2 hospitals. And then I got this cold call. I got this phone call. And it was the COO of this company, Perimeter Behavioral Health. And she says, listen, I just talked to your former supervisor who used to work with me, tried to offer him a job out here in Dallas, but he's got his own gig going on. Would you be interested in coming to Dallas and being the CEO of our 100-bed child program? And I said, no. I love Florida. I love my job. It's great here. I feel like I'm living in paradise. At any rate, she said, I tell you what, please come out to Dallas and visit with us. I want you to meet our CEO, Rod Laughlin. So she convinced me, and we came out, my wife and I, and met with herself, Lisa Evans, very bright woman, and Rod Laughlin. So we're at dinner, and Rod tells me his story. And his story goes, he adopted a 3-day-old child who eventually became diagnosed with autism and various mental health illnesses and struggled her whole life in and out of psychiatric units. Unfortunately, she succumbed to her illness at the age of 33. Rod watched her live her life in and out of psychiatric units. And so he created this company, Perimeter, to try to do different. He knew what didn't work. He knew what his kids and his experience of suffering and access and difficulties and all those things that we all in NAMI try to help people with. So he created this company, and it completely married with what I want to do, why I do what I do. I am in this because I really want to make a difference. I really want to help those like my brother. He had a missed chance, I feel like, and I try to help those in the same way. So that's sort of what guides me, and that's what brought me to Dallas. I've loved my adventure here. It's been a real experience. I've never worked in a children's hospital before, so this was a first experience, but it's been great. So I come before you guys today, humble in Dallas. I think we were having a conversation earlier about just how big things are here in Dallas. And I'm a New Englander, so I'm still a Tom Brady fan. But just saying, I know that doesn't go over well here. At any rate, I come before you guys today, humble and honored to be here, and just grateful that I even get an opportunity to speak with you and meet with you. So I'm going to do a basic primer on mental health. Some of these things I'm sure you guys already know, so I open it up. If you guys have questions along the way, I like an active, involved audience. You're welcome to ask me along the way. But I figure I'll give you sort of some of my lived experience with these different things as both a therapist and just a human being. So we'll kind of talk through it as we go through. Let's see, how do I advance this slide now? Down here in the corner. All right, so mental health and behavioral health are two separate terms, and a lot of people struggle with understanding what those two mean. Generally speaking, mental health is kind of just about your well-being. It's about having fun times and experiencing life, and it's not necessarily about illness. Behavioral health is the umbrella category of all of that. So mental health kind of rolls up to behavioral health. When we're looking at behavioral health, we're looking at everything. We're looking at the physiology, the psychology, the physicality, all of it. So within these categories, there are about 6 different foci that are important to realize that help us understand what mental health and behavioral health symptoms and illnesses look like. And they fall in the categories that are listed here. For those who can't see, I'll read them out to you. So the way you think, your perception, which is different than the way you think, your emotional state, signaling, which is outward cues that something is different. It could be nonverbal communication. It could be just the way that you think of Tourette's with a tic. It could be something like that. Physical, like how it may affect your body, and behavior, how it affects your behavior. So those are the 6 areas that we look for symptom sets or key identifiers that help us understand what maybe is going on with an individual. So in our diagnostic categories, we have several different sets of illnesses within our diagnostic manual that we use to make a diagnosis, and they all kind of fall under an umbrella category. So we have illnesses that fall within the anxiety disorder spectrum, mood disorders, psychotic disorders, eating disorders, impulse control, personality, OCD, and PTSD. I want to just look at my notes here just to give you a little bit of example. So anxiety disorders, generalized anxiety disorder, you may have heard of that. Phobias fall into that category. Panic disorders fall into that category. Mood disorders, the famous one, major depressive disorder, bipolar disorder. Cyclothymic or dysthymic episodes of kind of not quite super depressed or super manic, but kind of a little bit in the middle. Schizophrenia with a psychosis, that's obviously one that everybody knows. Schizoaffective, which is a bridging illness. It includes mood disorder as well as the psychosis. Eating disorders, anorexia, bulimia, binge eating. Impulse control, that's usually the addictions, alcohol, drug abuse, gambling, sex addiction, things like that. Personality, there are some famous ones here. Antisocial personality, I know a lot of people use that word kind of flippantly, but it actually is a very specific diagnosis. Borderline personality disorder, and there's histrionic, there's a whole slew of different personality disorders. Did you have a question?
No.
Thought you were. OCD, which again is used very flippantly around the community. Oh, my OCD is kicking in and I've got to organize. Well, it's actually a very debilitating illness. And PTSD. And I'm going to get into a little bit of detail on some of those going forward. Let's go to the next page. There's also a list of less common categories, but worth listing as well. Stress response, that is the new term for the adjustment disorder category. So think your child has just changed schools and they're not really coping well with the new school and they're really struggling. That adjustment, that change has caused a stress response. And so they're having some behaviors around that, right? Typically, these are things that are short-lived and can be very, very treatable with therapy and sometimes medications. Dissociative disorders, this is the famous split personality disorder, but we call it DID now, dissociative identity disorder, when you have multiples that you're interacting with. Factitious disorder, which is kind of interesting. That one is one in which a person, for whatever reason, for want of attention or for simply beliefs that they have taken on for themselves, they pretend or believe that they have an illness that they don't have for the secondary gains. So these are people that may live in and out of hospital settings, always saying that I have this illness, that illness, and all the studies and all the research that we do, we can't really determine where that's coming from. It's a really strange symptom set. Obviously, we have sexual and gender identity disorders, somatic symptoms, which are similar to factitious, just things that your body is experiencing. And lastly, the tic disorders, Tourette's being one of those. So a lot of different categories, right? We have many, many different ways in which we categorize illness and whatnot. What I want to do is break it down into some of the major ones so we can talk about some of the ones that you're most familiar with and maybe talk a little bit about what those look like in real life. I'm going to read it out loud for those who can't see, but depression, the first one, prevalence rate, about 5% of Americans ages 50 and up, or 6 million Americans have depression. It's believed that about 50% of adults 85 and up have depression. So it's higher risk the older you get. Only 10% of individuals actually seek and get treatment. So many people suffer in silence. I know that's where the "you are not alone" comes. Depression, it's a common illness, but it's not normal. Okay, and I want to talk about what that means in a minute. It is more common in females, but is a higher risk illness for males. And we'll talk about that too. So talking about depression is common, but not normal. When we get into actual diagnosis, there has to be a disruption to your everyday life. So to be diagnosable, it's not just I'm having an off day and I'm struggling with some feelings. You truly need to have it start disrupting your daily function for it to be a clinically diagnosable illness, right? And it has to be over a period of time too, not just brief. So individuals with depression, they may experience a great swath of various symptoms, which we'll cover here in a minute. But it is not normal, particularly when it starts interrupting your life. When you can't get out of your bed to get up and go to work, or you stop engaging with the friends that you once had, or you stop attending the activities that you once loved to do, you kind of fall out of society. You tend to sleep more or don't sleep at all, and you kind of withdraw from the world through television or some other vice that kind of gets your attention. When that happens, more days than not in a given week, for approximately 2 months or more, even 2 weeks or more, it could be diagnosable as a depressive episode, maybe even major depressive episode. Within that, I'm going to talk about the risks in a second here. Again, you guys can't see the screen, but causes include loss. So think about someone dying in your life, loss of a job, retirement. Some people get depressed after losing their kind of identity for their whole life, divorce, grief, anything that comes with that. Health changes obviously can bring depression. That's why a lot of the elderly start getting depressed. They have many health issues that restrict their ability to move and be autonomous. So it kind of works in both ways, right? The depression can pull you out of society, and sometimes the pulling out of society causes depression. You get what I'm saying? So that's why it really affects the elderly, who start losing their ability to drive and kind of engage with their family as much as they like. Maybe they enter a nursing home or an ALF and whatnot, and it can be a trying time for them. I do want to talk about situational situations and chemical imbalances. I think there's a difference between the two. What I mean by that is you can have a tragic accident, right? You can get in an accident, break a leg, or maybe lose a limb. And that itself is a situation that happened. that you now become depressed over, right? It affects your life. It makes it impossible for you to engage in the things you used to like. You begin to get depressed. After a period of time, we find that most illnesses, after a period of time of suffering an illness, you also have a chemical reaction that kind of triggers and engages. And our body likes habits. Our body likes to routine. It likes doing the same. So if you're depressed long enough, it's likely that your body's going to try to continue in that depressed state with chemical imbalance, okay? If you have a chemical imbalance long enough, your body's going to want to continue that. So that's why some of these illnesses get kind of hard to address. And particularly, again, if you keep in mind of how it affects your life, you're being withdrawn from the society, you're not going out with your friends. So all those things that would normally help you feel better are kind of cut from your life as a result of that depression. So that's what makes treatment very hard, right? To do treatment, I got to get up out of bed. And I got to be willing to suffer through a shower and putting my clothes on and get out the door. Some people can't even do that with the severity of their depression. Now I got to talk to a therapist. Nobody feels comfortable doing that, you know. So it's a constant struggle. And then lastly, the age-related changes, which I talked about. Symptoms, I'm sure you guys can garner what those are, but sad, depressed mood, anxiety episodes, emptiness, poor concentration, worthlessness, hopelessness, feeling of pessimism, nothing's ever going to change, insomnia or hypersomnia, irritability, restlessness, loss of interest, so on and so forth, right? So we're familiar with all of those. What people often don't know is that depression actually doubles the risk of a cardiovascular disease. It increases your risk of a medical death, so increases the chances that you will get medically ill and die from it, decreases the effectiveness of medical rehab or treatments, and obviously there's also the risk of suicide. The most severe depressions, you have this almost like, it starts sometimes as like a fantasy of suicide that turns into a gutting feeling that that's just the only way out. That's your only escape. The best description that I can give for you guys is to kind of talk you through an experience I had working at that facility up in Massachusetts. So I had a patient come in once, and of course I'm this young, fresh-faced, and I think medications, we don't need medications. I'm going to fix everything through simple therapy. And so I had this one patient come in, and he was by far to this day the most depressed person I've ever met. And I found that despite my chipperness and my desire to do well and my energy to try something new every day and continue to push and thrive and engage, I started to have this feeling of hopelessness. Like there was a black pit or a black hole in the room, and it was just absorbing all of the positive energy, all of the hope and dreams that I had for this person through that person's own depressed mood and despair. Nothing you said could make a change. He was convinced that his life was over, that there was no saving him, there was no redeeming him, and that day in, day out, black hole, it's crushing. It's absolutely crushing to the extent that people around you can feel it. I mean, that is, to me, the most severe episode that I saw. And that man really struggled with kind of regaining autonomy and getting well. And then I learned that medications do sometimes have to help because, you know, no amount of my efforts on all the different therapies I had learned in school really made an impact. But medications did start to help for this gentleman. So that is, if you're working with somebody, you might start to feel that sense of hopelessness, that sense of nothing's working. That might be the first sign that you're really dealing with a deep depression. You guys can't see this, but I've got a picture for you guys of celebrities diagnosed with depression. I think it's important to normalize this. Depression, well, really, mental illness has no prejudice. There is no place in the world you can hide from it. There's no civilization that's been excused from it. Your gender, your age, your affluence, your poverty, none of that matters. Behavioral illness, mental illness will have the same prevalence for the most part, regardless of all of that. There are some differences in genders and there are some differences in races, but for the most part, mental illness exists everywhere. So I'd like to normalize that by displaying a few celebrities that have themselves come forward and said, hey, I've suffered from this and I'm advocating for improvement. So we've got The Rock, we've got Owen Wilson, and we've got Hugh, oh my God, what's his name? The guy from The House. The guy from House.
Hugh Laurie.
Hugh Laurie, thank you. And then, of course, we have a few celebrity females here, Drew Barrymore, and I'm terrible at this, guys. I wanted to show you guys the pictures and you guys can say it. Gwen Stefani. And honestly, I don't recall who's the last one there. I'm so sorry, famous person. Please don't be watching this. And I put a comic up there for you guys, and there's this beautiful image of a unicorn running on a rainbow with money flying, and it says, "How people see my life." And then there's these dark cave with these like demon figures coming up, and how I see my life, this black pit, right? And that is often the case, and that's part of the suffering in silence. We all feel like we got to put on a face too, and pretend like we are not suffering when we actually are. The next one I'll talk about briefly, bipolar disorder. So 5.7 million American adults, or 2.6 in the US population, 2.6% of the US population. Onset of this is about 25 years old, which means it actually affects people in childhood, and all the way up to age 50, you can be diagnosed for first episode of bipolar disorder. There's pretty much an equal prevalence among men and women on this one. 2/3 of individuals diagnosed with bipolar disorder have at least one close relative with the same diagnosis. So it indicates that there's a habitual, heritable component to this, that it's partly genetic. So bipolar disorder, as you guys probably know it, comes with ups and downs, right? We have kind of manic episodes at the most extreme, followed by depressive episodes. And there are a couple different types of bipolar disorder based on how long you're in each of those phases, or where your high is and where your low is. But if we talk it generally, a manic episode consists of, just think of like having an adrenaline shot. You are go, go, go. You physically don't need to sleep anymore. You physically can go, go, go nonstop. Don't need to eat. You talk really fast. Sometimes you talk so fast, you're not making any sense, but in your head, you're making perfect sense. You can go 4 or 5, sometimes I've even seen someone 6, 7 days without sleep. Well, that obviously is not very healthy. And the longer you go without sleep, sort of the more difficult you are to understand. And that manic episode typically lasts a week, 2 weeks at the most, and then they flip into a depressive episode, which in the most common version, we see 2-3 months of depression, which we just described. So you have that, and then you flight back up to a depressive episode. Very, very challenging illness, can be absolutely debilitating to have. But at the same time, there are many people that have learned to live with the illness and sort of have become famous for it. And when I get to the celebrities, we'll see that. But causes, again, no one really knows the absolute cause of any mental illness. But in this group, genetics is one of them. We think brain structure may have something to do with it. Seasonal depression can trigger it. You know, when you have episodes of depression based on how much sunlight is available. Anxiety disorders might also trigger a bipolar episode. Obviously, family history, stress levels, if you have a lot of stress, drug and alcohol use. That one's interesting. I want to throw something else out there. Again, in my neophyte way of trying to understand the world and understand behavioral health, I saw a lot of folks come in with substance use issues as well. And I found that when I watched somebody who is not suffering, but having high doses of cocaine use, kind of looked to me like bipolar disorder. They'd have these manic pushes, this high, this really, really euphoric feeling, and they feel invincible, followed by, it's a little shorter period, it's not a week, followed by an immediate crash where they feel miserable and they want to commit suicide often. So when I saw people with severe cocaine use, I was like, wow, that's like a mini bipolar disorder episode, that high mania. Obviously, symptoms, extreme emotions, it can come with irritability, rage, agitation, restlessness, pressured speech, which, think of a fire hose, words just coming out so fast, faster even than humans think, words are just spitting out. It can come with increased libido, increased energy, decreased sleep, sometimes paranoia. The later you stay awake, you might sometimes have hallucinations, paranoia, and even delusions if you stay awake long enough. Sleep deprivation is not a friend in these illnesses. A lot of folks that I worked with in this illness, though, preferred to be bipolar without meds because they had liked the manic episodes. There's a euphoria that comes with it. That was always the challenge, is trying to talk through somebody that's in a manic episode that this isn't healthy. So ways that it may not be healthy, right? Let's think about that. You may engage in substance use if you never even used it before, but suddenly you feel omnipotent, you feel all powerful. So why not? Let's do substances too, because I'm not going to get addicted. It's not going to hurt me. You can have heart and cardiovascular problems, of course, staying up and all that, high blood pressure, diabetes, unhealthy weight from overeating. Just think of overindulgence across the board. I did unfortunately meet one gentleman who in his manic episode sold all of his facilities. He was a rich man and he sold them all in one fell swoop and lost his entire fortune to a unscrupulous person who took advantage of that. So massive financial loss, promiscuity, STDs, physical injury, because I've had people try to jump from buildings thinking that they can fly, and accidental death as a result, right? So it can be a very, very challenging illness. And not to mention, that's just the manic side. Now take back all that, all those depressive symptoms we talked about. And I did skip one. I told you I'd get back to it and I missed it. Why is depression more lethal to men? It's a question for the audience. Do you guys know? So more men than women die from depression. Now, women have more prevalence of suicidal ideation, but men are more likely to commit suicide. Do you know why? That's part of it. They are less likely to seek help, and men tend to choose more lethal means. Being the more physical of the genders, we tend to pick ways that are more lethal. Guns, hanging, knives, things that are more permanent. Where females tend to do more overdose attempts or small cuts that maybe won't be lethal as fast, where there's a period of time where you might seek help, right? You might overdose, but you can be found and saved before that overdose actually kills you. But men choose more permanent results. So men are 3 times more likely to succeed with suicide than women for partly those reasons. So again, now we're talking bipolar disorder, you have the manic episode, now you fall down into the depressive episode and you have that risk as well. So it's a very, very challenging illness because it can be life-threatening. So celebrities here diagnosed with bipolar disorder. There's a common theme here. So Jim Carrey, Robin Williams, Russell Brand, Mariah Carey, Kanye West. The first 3 I listed, all great comedians. Before his passing, Robin Williams talked about his illness a bit and explained that some of his best comedic acts were when he was in a manic episode because he was just vibing it. And he was able to kind of sustain that vibe. So there are folks that live with these illnesses and can manage despite the illness, but obviously they have their challenges as well. We all know what happened with Robin Williams also, so kind of a tragedy there. So I have another comic here. So it's a picture of a woman standing over another woman who's lying on her back, and she says, "You were so happy and energetic yesterday. You got so much done." And now she's depressed, right? So that can be the case, right? You can feel super empowered and even omnipotent with a manic episode. But then when the depressive episode comes in, you're kind of back in that funk and you're unable to really engage. So next one I want to talk about, another very common one, or at least common in our society, schizophrenia. It's actually less than 1% of our population that have schizophrenia, but it tends to be the one that rises up the most in terms of what hits the news and what hits the media and sort of the slapstick jokes about folks with schizophrenia. The multiple personality thing coming most frequently to mind, like, oh yeah, I got multiple personalities, and that was my other person. A lot of those jokes come from this illness. 23 to 57% of these individuals also have depression, 10 to 15% also have panic disorder, 12 to 29% also have PTSD, 12 to 23% also have OCD, and 50% or more will have lifetime substance use issues. So it's a illness that is very pervasive and can also touch on so many other areas of the brain that affect some of these other illnesses. So schizophrenia is actually a diagnosis that should be long in coming to. Usually over the course of 2-3 years, you're observing before you get there. You start usually with like a psychotic break. A psychotic break, and I'm sure you guys have heard that term before, but it's essentially an episode of just bizarre behavior or bizarre thinking that previously you never had. For men, that usually happens between 18 and 25. And for women, it's often a little older, 25 to 30. They can also happen younger, but that's generally the age that those things happen. I have met many a 19, 20-year-old young man who's athletic and sports and college, and suddenly they have their first psychotic break. I actually met with and followed a patient for many years that was very, very well off until he had his psychotic break and then struggled with schizophrenia the balance of his life. It was very tragic. So schizophrenia obviously is illness that is very difficult to deal with in its most extreme states. Although there are many people that actually seek treatment very successfully and can live very productive lives. It's about a third. About a third of individuals can kind of overcome the symptoms, can be in treatment and be very successful. And you may not even know that they had schizophrenia. You might just think sometimes they have an odd idiosyncrasy or something. Another second half that struggle on and off. They can kind of hold down a job, but nothing too engaged, nothing with too many long expectations, right? And then a third that probably can't really hold much in the way of gainful work, but they could do volunteer work, and because they just struggle with this illness, it's pervasive in their life. Unfortunately, schizophrenia is also somewhat of a degenerative disease, meaning that, oh, I never changed that up top. Sorry, guys, audience, it says bipolar, but it's actually schizophrenia. So what was I saying? Brain scans of individuals with normal brain versus schizophrenia, you actually will see a potent change over time. The brain actually changes significantly and atrophies a bit. And the areas of the brain that fire in a schizophrenic person, well, I shouldn't say it that way, sorry, a person diagnosed with schizophrenia, I'm trying to be PC here, versus a person without schizophrenia is pretty vibrant. You can see it in the MRI very clearly. So there's definitely brain chemistry that's changing in a person diagnosed with schizophrenia. It's heavily genetic. If there is somebody in your life that has schizophrenia, it's much more likely that you or a loved one will develop schizophrenia. There are physical factors, meaning it affects your physicality, your coordination, hand-eye coordination, that kind of stuff. There are psychological factors, clearly, psychosis and odd thinking and things like that, which we'll talk about in a minute. There might be environmental factors that play into it. There could be exposures to certain elements or certain things in the community that might cause that psychotic break. So what I mean by that is it's possible that a stressful event, I mean, think of your brain as a very, very complicated organism that seeks its own survival. And sometimes to survive a tragedy, it will invent a new reality. And that is the break, right? So this world that I'm in is dangerous, but I invent this alternate reality that my brain believes in, and that's less dangerous because I'm in a alternate reality than the real world, right? People who suffer from severe trauma, physical, sexual abuse as children, things like that, have a higher likelihood of developing psychotic break. Drugs and alcohol have a significant component to this. I always like to point out that while many of the states are legalizing marijuana by itself is actually a hallucinogen, some components of it. And what's one of the first things that people say they experience when they smoke marijuana? Paranoia. That's a major symptom of schizophrenia, right? So I usually point that out to folks that I've met in college days, and they're like, never thought of that. I never thought that might be connected, right? So positive symptoms and negative symptoms. Let's talk about that. Positive symptoms are anything that's added on to your persona. So this could be auditory hallucinations, hearing voices. And again, brain scans actually show that their auditory lobes are firing. They are hearing something. It's not just in your head, a self-talk you may have. No, they're actually hearing something. We can have visual hallucinations. It's pretty rare actually in schizophrenia. Visual hallucinations, and particularly tactile hallucinations where you feel like bugs crawling on you, usually that has more of a medical rationale and explanation, but it can happen. Command hallucinations, which are the scarier of the types, these are voices that are actually telling you to do things, which sometimes is nothing, like, oh, go pick up that apple. sometimes it might be something violent or something tragic or something you shouldn't do. Go kill yourself, go do this, go do that. They can be very, very difficult to resist. Delusions, so these are beliefs or thoughts that aren't necessarily real, but they could be based in reality. I'm going to give you guys an example of that in a moment. Paranoia, which we talked about. And then there's things called negative symptoms. These are things where your personality has something taken away. So think flat affect. You struggle with showing emotion. You may develop catatonia or episodes of mutism where you don't talk for a while. Aphasia, where you struggle with getting words out. You just can't, you want to say something, but you can't process the words to get them out. Word salad, when you do say something, it's all mixed different words and doesn't make sense. So these are all things that are sort of taken away. So it's a combination of these symptoms. For the diagnosis to be quantified, we typically look for 5 to 7 symptoms over the course of an extended period of time. And 2 years, 3 years, we're really looking at longevity to really go with this diagnosis because it's a pretty heavy one as far as stigma goes, right? So back to delusions. I want to give you guys an example of something that I learned. And also admit that I'm not perfect either, right? So I had a class that talked about the differences between delusions and fixed delusions. And fixed delusions being things that are sort of rooted and aren't going to change. Like no amount of therapy at this point is going to change it because it's rooted in there and it's really deep-seated. And so one of the things that we learned, at least back when I was in school, was you don't want to feed a fixed delusion. So you don't want to verify a delusion because it might become a fixed delusion. So if somebody says, oh, my grandmother's right there, don't you see her? What's the proper answer? I'm sorry, I don't see her. I understand them. Maybe you are seeing her or hearing her, but I don't see them, okay? Because if I say, oh yeah, I see her, that person's looking for outside validation of their reality. And when you validate that, you have a higher likelihood of making it a fixed delusion where, oh yeah, people see it too. So it's real for them. And their perception is reality, but we try very hard not to push them deeper into that psychosis, right? So I had a gentleman come to me, had a history of schizophrenia, and was telling me how everyone was watching him. The government was after him. They were tracking him, monitoring him. Everyone was after him. And to the extent that they quite literally are monitoring him in his own home, they put up cameras all over the place. There's cameras all over his neighborhood. They're all watching him and they're all out to get him. So obviously I'm asking him, well, what would make that happen? Do you have some secret information? Did you work for the government? Like what would cause? Well, no, he didn't have any of that, but he was convinced that these cameras were for him. So of course, fresh off my training, he says, you believe me, right? You believe me. And I say, well, sir, honestly, no, I don't believe that the cameras are all watching you. I don't believe that there's things pointing at your bedroom, looking at you. It's hard for me to understand why that would be. So I'm trying not to endorse a fixed delusion, right? So anyway, treatment goes, he eventually gets discharged. Well, probably 2 months later, I just happened to drive through the neighborhood where he was living, and they had just put up a crime watch thing with all cameras all over the place. And I was like, ooh, got that one wrong. He was right. He was right. There were cameras everywhere. On the corners of every building, there were cameras. So I kind of looked at myself. I was like, wow, I really got that wrong. However, I still to this day do not believe they're there for him. Yes, the cameras are real. Yes, they are up there, but I don't believe they're there for him. So anyway, there are downsides to our own systems too, right? So risks with schizophrenia. Folks with schizophrenia can actually have a shortened lifespan by upwards of 29 years. Exactly. They're more likely to die of cardiovascular illness, lung cancer, because they're more likely to smoke, influenza, pneumonia. Folks who suffer from schizophrenia are often more likely to be incarcerated or be homeless. So they're more adverse to the elements. They're greater likelihood of suffering from an accident, getting hit by a car. They may not be, completely paying attention because they're responding to something in their world, or die simply of a substance overdose, not intentionally. Although some people with schizophrenia also commit suicide intentionally. So again, a challenging illness to have. Celebrities diagnosed with schizophrenia, and I'm going to be dead honest with you guys. I don't know any of these folks. It's it's a black and white image that okay, I'm going to be honest. I just pulled it down off the internet, right? I did a search, schizophrenia, I pulled it down off the internet. I don't know any of these folks. And part of it, I like to believe, is that there may be celebrities that have schizophrenia that are in that category of folks that can gainfully work and be very successful. But I think the odds of that are small, and also the average age of a person with schizophrenia tends to be shortened. So they may not reach stardom. But I don't know. I'm not entirely possible. This is me making a hypothesis. You guys are going to have to go back and watch so you can see it. So I'm trying. It's probably better not knowing, right?
And you can part is recording on the website with slide pro.
All right, great. So I have another cartoon here. It is a young man sitting on the therapy couch with a psychiatrist, presumably sitting in the seat. And again, I just pulled this down off the internet, but he's got headphones on, and the doctor says to him, "When did you start hearing these voices?" Not really something you can laugh at, but I thought that one was good. PTSD, so post-traumatic stress disorder. 7 to 8% experience PTSD at some point in their life. More prevalent in women, can develop at any stage of life, and does not need to be based in reality. I have a story there too. The image I have for this guy is because PTSD over the years has always had a face for the PTSD, right? For a long time, it was the Vietnam vets. Then it was some of the other military folks, and there is no doubt in the armed forces, the rates of PTSD are very, very high. Now it's an image of a doctor with COVID in the background, right? I mean, reality, a lot of those doctors suffered PTSD because they saw life and death all day, every day, at an alarming rate. So that is the newest one that I could pull up. So PTSD causes sudden and intense trauma. So think of this. You are driving down the road and you're going through the same intersection that you've gone through a million times in your life. And this particular time, somebody T-bones you. It's a very dramatic accident, very, very difficult to get. What's the likelihood that you're going to want to jump back in that car and drive the next day? Once you're healthy, right? Not very likely. You're going to be scared. You're going to be scared to drive. When you approach that intersection, or what's the likelihood that you will even go through that intersection again? You'll probably avoid it, right? You'll probably change your lifestyle to get away from that spot. So those are some of the seeds of PTSD. The symptoms of PTSD are obviously much more intense. Massive episodes of panic, fear, anxiety, fight or flight. Some folks, that's their reaction. They're going to get violent, or they're going to get scared and run. Self-destructive behaviors. You may harm yourself as a means to kind of just take your focus off the world around you, the scary things. Social isolation, emotional detachment, unwanted thoughts, mistrust in others. Oftentimes PTSD is a result of trauma, sexual, physical abuse, things like that. The people you trusted most in life to take care of you and to treat you well offend upon you. It's really hard to recover from that, right? So PTSD can be as a result of that, rape, any other things. Now, it does not have to be a reality. And this is the other part that was kind of interesting to me. I didn't really understand that until 9/11. So I was working as a therapist when 9/11 happened. And a few months after 9/11, we had a lot of folks get admitted to us that had stories about their tragedy related to 9/11, because we lived in Massachusetts, so it wasn't very far. You know, the relatives, it's not a very far miss, right? I can probably meet someone here in Texas that I know from back in Massachusetts, but when you're that close, you actually have a lot of folks that went through it. So we had a lot of people come in with real life struggles of loved ones who had passed, or they were on scene, or they were responders, whatever it may be. Well, I had one particular person come in who did not go to 9/11, was not there at the time, was living actually down south somewhere, witnessed it on television. So it was not a event that they experienced themselves. They simply watched it on television, and that was enough to trigger a massive PTSD episode for this person. She was really suffering from it and needed desperate help. I had another person, maybe 2 years later, another person who had a perceived trauma that happened to them. Something, I don't remember the details of it, but something that didn't physically happen to them, but they believed that it was targeting at them And that triggered a PTSD response. So it doesn't actually have to be something physically done to you or around you. It can just be a perception that this thing was about you. And that perception can be enough to trigger a PTSD type response. PTSD can often result in lifelong struggles of dealing with these episodes of struggle and angst. It's not necessarily PTSD, but I'm going to give you guys a personal story. We have a thing called trans crisis points. That means at some point in your life, you have re-experiencing of a certain trauma, a certain issue, and people with PTSD certainly can experience this by way of flashbacks, or again, if you end up driving again and you see a similar car, maybe you have that same pang. I don't know about you guys, but no matter how good of a driver I am, anytime the lights go off behind me, I have this panic moment, right? So a trans crisis point is when you have a trauma or a situation, and then you kind of relive it again at some point later in life. Something triggers it. So I'm going to tell you what mine was. So obviously I went through all the struggles with my family and that loss that we had, got into college and school and thought I had done all the counseling that I could around this and felt pretty stable, right? I was in my post-college years. I think at that point, living with my then-to-be wife, I was living with my girlfriend. And I just happened to stay up late one night and watch this show. I don't know, you guys ever see this show, The Medium? Seen that show? So it was with Patricia Arquette, was the actress. I like the show. They're very interesting. She basically could sense, and she worked with the police department because she could sense kind of the spirits or the auras of people who had passed, and she helps solve mysteries, right? So she's the medium. Well, there's one episode, and my brother committed suicide by firearm. So there was one episode where, and I don't want to put anybody into tragedy, but husband and wife are fighting, and the wife ends up shooting herself and doesn't die immediately. She actually bled out, and I didn't realize that could happen by the age of 30 or whatever it was. And so I had this massive emotional crisis, picturing that my brother may have suffered. You know, you always think with a firearm, it's done and done, right? That triggered something in me, and that was my trans crisis point. I kind of relived it all over again because I had a new perspective on what that might be like, and it was very, very tragic for me to kind of go through that again. It's like it just happened yesterday. So with PTSD, you can have symptoms like that where that tragedy, somebody looks like the offender, something smells like it, something sounds like the prior trauma, and boom, you're right back in that episode and you're reliving it all over again. Even after all the therapy and all the treatments you've engaged in, you're right back in it. So it can be another very difficult illness to overcome. That actually concludes the major illnesses that I want to, oh, there, look at me, I put it on the next page. Risks, increased blood pressure and heart rates, fatigue, muscle tension, nausea, joint pain, headaches, back pain, or any other types of pain. Oftentimes this particular disorder plays itself out on the body. You feel somatic symptoms, you feel pain, you feel stomach and back aches and fibromyalgia and things like that. So this is my thank you page, but for you guys, one day only. I'm going to talk about the personality disorders real quick, because I mentioned them earlier, antisocial and borderline personality. Those tend to be the most famous ones because they tend to be the most challenging sort of to society. A lot of people run around and say, oh, well, they're just antisocial. What they mean by that comment is they don't get along well with others. When in fact, people who are diagnosed with antisocial personality disorder tend to be the most charming people you ever met. They tend to be very engaging. It's definitely more men than women. They tend to be very engaging. They're really good at getting in close with somebody. They're not really good at sustaining the relationship, but they're very good at kind of getting in close with somebody. They, for whatever reason, it could be childhood trauma, it could be biology and brain mechanisms or whatever. For whatever reason, their morality is not the same as most every other people, right? They tend to have offended on animals. They might kill animals or hurt animals growing up and didn't really feel bad about it. You know, there were the kids that went from burning the ant to actually shooting BB guns at the birds to actually killing the family cat kind of thing, and not really feeling that pang of remorse. That component is just not fully developed in them. So the scariest of situations with someone with antisocial disorder is they tend to have the ability to be very savvy criminals. So a lot of folks with antisocial disorder end up getting arrested for something or another. A lot of others can become very, very well off in society because of their ability to sort of charm others and whatnot. But it's that lack of morose, that lack of sort of that moral fiber of doing harm to others and not really feeling bad about it, that kind of identifies that illness. It's obviously a tough one to work with, right? So it's hard to teach that in somebody if it's missing. Borderline personality disorder, the other side of the coin, this affects mostly females. And borderline personality disorder is in its essence a response to abandonment, real or perceived. So real or perceived abandonment. So these are folks that are terrified of, often they're terrified of being abandoned, being left alone, being not cared for. So what you tend to see with these folks is behaviors that they learn to kind of prevent that from happening. And they start to have almost like a push and pull. They will push you away, and the second you're like, I'm done, then they glom back onto you. No, come back. Like, no, love me, care for me, I'm here, right? These are folks that may do self-harm behavior on their wrists and arms. Usually it's to get the attention of others. It's not really to harm themselves, but it also could be to feel the sensation of pain. Usually when we're working with this type of individual, if you don't know the diagnosis right off, just the feel of it, when the whole treatment team starts fighting with each other about what's going on with the patient, we usually can tell, oh, there might be a borderline personality sort of playing out here because they've somehow got all of us fighting with each other, right? So they're really good at triangulation. And again, it's the illness. It's not them as a human. It's not them as a person. It's not what they want, but that's sort of the illness manifesting to try to prevent and manipulate their situation, manipulate their environment to keep them from being abandoned, because that's the ultimate fear with, and unfortunately, a lot of these folks have had abandonment in their life. Their families have abandonment at one point. So anyway, I just wanted to cover those two too. Let me give you some statistics. About 3.91% of folks get diagnosed with antisocial disorder. About 1.6% of the general pop get diagnosed with borderline personality. It's again, antisocial, deep ingrained and rigid dysfunction, socially exploitive, oftentimes delinquent or criminal, mostly men. Borderline personality disorder, while it's 1.6% of the general population, approximately 20% of females in inpatient psych units have borderline personality disorder. They tend to find their ways to inpatient. Abandonment, self-regulation type behaviors, mostly females. And that's where Marshall Linehan came up with a treatment, dialectical behavioral therapy, specifically designed to try to keep those folks out of the hospital, because there's great secondary gains for somebody with borderline personality disorder in a hospital, right? They have that, they get that attention because we have to give it, right? We're your hospital mates. We're going to give it one way or the other. So they can kind of play that push-pull on an inpatient unit much easier than they can in the community. So anyway, I just wanted to mention a couple of those too, because those are ones you may see as you go about your life. But that concludes my presentation. I want to say thank you. And also, does anyone have any questions or comments they want to make about some of these topics we covered today? This is where everybody looks down and doesn't look at me. I know they're done when no one looks at me in the eye, like I'm done. You know? Very good. Did you have a question?
Yeah. Aphasia.
Inability to bring words to the front, right? So you might be thinking an answer. So you ask me a question, I'm thinking the answer, but I can't get the words out of my mouth. The words won't come.
I've experienced it and not had language for it. So I've lived with my diagnosis for over 20 years.
Sure.
This is the first time.
Aphasia, yeah.
Yeah, even known to explain.
Yep. There's an actual term for it. And again, it's one of those negative symptoms we talked about. It's one of those things that you kind of lose the ability to vocalize your thoughts. You have them, you're thinking them, you know what you want to say, but the words just won't come. I mean, some people seem to experience that when they're just, what is that word again? Who's that person? And they feel that, but this is really a more invasive thing because it affects your ability to communicate, right? So you're trying to say what's happening and you can't.
And my brain moves.
Mhm.
Like, it's intense.
It's intense, yeah, yeah. So it's beyond just the, I can't remember her name, what's that actress's name that I was doing earlier? That level of aphasia is nothing compared to what someone who's really suffering from feels. Yeah. Any other questions,
I
comments?
found that really interesting when you talk about the state show that actually. Or the presentation about schizophrenia, and talked about that a lot of the medications that they use just kind of lower the voices, but they don't ever really that if you have that illness, you just have to learn to sort of block it,
Sure.
just lower the voices.
That certainly can be the case with some people. What I find works for some people is listening to music, or if others around them are engaging in conversation that they're interested in, the voices kind of disappear. It's similar to Tourette's syndrome in that sense. When you're focused on a task, the tics kind of go away. And for some people, when you're focused on a situation or a task, you can actually dim the voices or maybe even make them not occur. For a more severe illness, it may be more and more difficult to do that. So you're hearing that in the background. And it's not always voices, by the way. It sometimes can just be murmur sounds, heartbeat sounds, just noise in the background, white noise kind of sounds. It can be a combination of any different thing. It can be screaming and yelling too. Does Notney still do the in your own voice? We do, right? Where they do some of that experiential. Yeah, so I went through that and it was powerful to put on the headset and hear presumably what somebody with that symptom set hears. I've experienced in being in that classroom, 2 or 3 of my peers break down in tears because they had a loved one, but that's what they explained, and they never really got it until they put that on. They were like, oh, I didn't realize I thought it was your internal voice. That's what a lot of us who don't have the illness think. Well, it's just that internal voice talking to you. You just forget it. No, they're really hearing stimuli from the outside world. It's just being created from their eardrums in or from their brain out, if you will. So it can be very, very debilitating. Other questions? I would love to take questions from our online audience, but I'm not going to give out my phone number. So, all right. Well, thank you all. I appreciate you, and I appreciate the opportunity to be here. So I'm going to go ahead and sign off somehow off of here.